I want to begin with something that took me a long time to say out loud, even within medicine. More testing is not always better. That sentence goes against something deeply embedded in modern medical culture. The idea that information is inherently good, that knowledge is always protective, that finding something is always preferable to not finding it. And in many situations, that idea is correct. There are tests that save lives. There are screenings that catch things early enough to make a genuine difference. I've seen that happen, and I believe in it deeply. But I've also seen the other side of that equation, the side that doesn't make it into the brochures or the health awareness campaigns. The patient who came in for a routine check and left with an abnormal finding that turned out to be nothing, but spent 6 months in a state of anxiety that affected their sleep, their relationships, their ability to be present in their own life. The patient whose test triggered another test, which triggered another, each one extending the chain of worry further into the future. The patient who, in trying to be proactive about their health, underwent something that created a problem rather than preventing one. These are not rare stories. They are common enough that they have their own name in medicine: overdiagnosis and overtesting. And after 65, this is a conversation that I think everyone deserves to have, calmly, honestly, with full awareness of what it means and what it doesn't mean. Today, I want to have that conversation with you. I've been practicing medicine long enough to have developed a kind of respect for complexity that I didn't have when I started. When I was younger in my career, I ordered tests with considerable confidence. The logic seemed unassailable. The more you know about the body, the better equipped you are to help it. And that logic isn't wrong exactly. It's incomplete. What I've come to understand, through years of watching what actually happens after tests are ordered, is that a test is not just a piece of information. It is an event in a person's life. It has a before and an after. It produces results that require interpretation, and interpretation is not always straightforward. It can trigger further actions, further tests, further procedures, further decisions that have their own consequences, their own risks, their own demands on the patient's time, body, and psychological state. A test set in motion a chain of events that extends well beyond the moment the result is received. And after 65, the length of that chain and the weight of each link in it is different than it was at 45. The body's reserves are different. Its tolerance for certain procedures is different. Its ability to recover from interventions is different. The time horizon within which a finding is relevant changes. What this means, practically, is that a test that is clearly appropriate and beneficial for a 50-year-old may carry a different risk-benefit calculation for a 75-year-old. And that calculation is not always being made as carefully as it should be. Let me describe a pattern I've seen more times than I would like. An older patient, let's say someone in their late 60s or early 70s, someone who is managing a few chronic conditions reasonably well and who sees their doctor regularly, goes in for a routine visit. The doctor, being thorough, orders a panel of tests. Some of them are clearly relevant to the conditions being managed. Some of them are part of a standing protocol that gets repeated annually or every few years, almost automatically, because that's the interval established at some earlier point, and the interval has continued on its own momentum rather than being revisited based on the patient's current situation. One of those tests comes back with a value that sits outside the normal range. Not dramatically outside, but outside. The patient is called with the result and told that further investigation is needed. They experience the particular anxiety that medical uncertainty produces. The sleeplessness, the catastrophizing, The Google searches at 2 in the morning? The rehearsal of difficult conversations they hope will not need to happen. They go in for a follow-up. Another test is done. Then perhaps another. Each test, individually, is ordered for a reason. Each physician involved is doing what they believe is appropriate. But no one is standing back and asking, does this chain of investigation, taken as a whole, serve this particular patient's well-being? Sometimes the answer is clearly yes. The investigation leads to something that needed to be found, and finding it leads to treatment that helps. That happens. I'm not dismissing it. But sometimes the answer is more complicated. Sometimes the original abnormal value was a variation, real but not clinically significant for this patient at this stage of their life. Sometimes what gets found in the follow-up investigation is something that would have caused no symptoms, no reduction in quality of life, and no meaningful shortening of life if it had never been discovered. But once discovered, it demands a response. Decisions must be made. Treatments are considered. And the treatment itself carries risks that, in an older body, may be more significant than the condition being treated. This is the heart of what over-testing can mean. Not just the inconvenience or the anxiety, though those are real, but the possibility of being propelled into a cascade of medical events that began with a test that was ordered automatically, without a specific clinical question it was intended to answer. I want to talk about something that doesn't get discussed openly enough in medicine, because I think it helps explain how this situation arises so often. Medical guidelines, the formal recommendations about which tests should be performed, at what age, and at what intervals, are developed through large studies and expert consensus. They represent the best collective judgment about what serves the greatest number of people. And they are genuinely useful. They have contributed to enormous improvements in health outcomes over the decades. But they are averages. They are designed for populations, not for individuals. And when a guideline is applied to a specific person with their specific health status, their specific life circumstances, their specific values about what they want from their remaining years, the guideline may or may not fit that person's actual situation. This is particularly true at the older end of the age spectrum, for a reason that is both simple and significant. Many of the major screening guidelines were developed primarily using data from younger populations. The evidence base for screening benefits in people over 70, over 75, over 80 is considerably thinner than the evidence base for people in their 40s and 50s. Yet the guidelines and the clinical habits that grew up around them often continue to be applied automatically, without explicit consideration of whether they translate to older patients in the same way. Some major medical organizations have begun addressing this. Guidelines for certain screenings now include explicit upper age recommendations, suggesting that beyond a certain age, or beyond a certain life expectancy, the benefit of a particular screening is unlikely to outweigh the burden it places on the patient. But these nuances don't always make it into the clinical encounter. The reminder appears in the electronic health record, the protocol gets followed, and the test gets ordered. I'm not suggesting that physicians are careless. Most are doing their best to be thorough, to be diligent, to ensure that nothing is missed. The problem isn't negligence. The problem is a system that has built-in reflexes toward doing more, and has not built in equally strong reflexes toward asking whether doing more, in this specific case, for this specific person, is actually serving them. Let me tell you about one category of testing that I find myself thinking about particularly often in older patients, and that I believe deserves considerably more individual assessment than it typically receives. Imaging tests, scans of various kinds, of the brain, the spine, the abdomen, the chest. These are powerful tools. They can reveal things that nothing else can reveal. In the right clinical context, with the right question being asked, they are invaluable. But here is something that is clinically well established, and that most patients are not aware of. Imaging tests, particularly in older adults, very frequently find things. Not because older bodies are riddled with disease, but because older bodies are complex. They have decades of history written into their tissues. They accumulate what radiologists sometimes call incidental findings, things that are visible on the scan, but that were not what the scan was looking for, and that may have no clinical significance whatsoever. A small spot that could be benign or could require follow-up. A slight change in a structure that may be age-related or may indicate something that needs investigation. An abnormality in a lymph node that looks different from the tissue around it. Each of these findings, once noted, demands a response. The radiologist notes it in their report because they cannot determine its significance. The ordering physician is now obligated to address it. The patient is informed. And what began as a scan ordered for one reason, perhaps a specific symptom, perhaps a routine follow-up, now has a secondary result that sends the patient into a new and unanticipated branch of investigation. In younger patients, the calculus is often clearer. The time horizon is longer. The potential benefit of investigating an incidental finding is more likely to outweigh the costs and risks of investigation. In an older patient, someone whose life expectancy may be shorter, whose body is less able to tolerate further procedures, whose quality of life is already the primary concern, the calculation is genuinely different. And I have seen cases, more than I wish I had, where the investigation of an incidental finding caused more harm to a patient's well-being than the finding itself ever would have. There's another dimension of this I want to address because I think it touches something that is both psychologically real and medically significant. The experience of being a patient who undergoes many tests is not neutral. It is not simply a series of data collection events that leave the person unchanged. It shapes how people understand their own bodies. It shapes their sense of whether they are healthy or unwell. It creates a relationship with the medical system and with the concept of their own health that has consequences of its own. I've noticed something in patients who have been through extensive testing, particularly testing that has produced uncertain or ambiguous results. They develop what I can only describe as a kind of vigilance about their bodies that becomes its own source of distress. Every symptom is scrutinized with a new intensity. Every sensation that would previously have been registered as ordinary, a temporary ache, a change in digestion, a moment of fatigue, now becomes a potential signal, a possible indication that the testing was right to be concerned, that more investigation may be needed. This is not hypochondria in the pejorative sense. It is a rational response to an experience that has taught the person that their body contains things that need monitoring, that abnormalities exist, that vigilance is warranted. But the vigilance itself carries a cost. The chronic low-level anxiety of someone who feels their body is potentially harboring something undetected. That anxiety is physiologically real. It affects sleep. It affects cardiovascular function. It affects immune response. It affects quality of life in ways that are not captured in any outcome measure used to evaluate a screening test. And for an older person, whose primary concern may not be adding years to their life, but maintaining the quality and peace of the years they have, The toll of this kind of medical anxiety is particularly significant. Most people don't talk about this openly. There is a sense that worrying about one's health is appropriate and responsible, that it would be irresponsible not to investigate every potential finding. But the anxiety that medical uncertainty creates is a legitimate harm, and it deserves to be weighed against the potential benefits of investigation with the same seriousness we give to more quantifiable outcomes. I want to be careful now to say something clearly, because I'm aware that what I've been describing could be misread as discouragement from medical care. That is not what I'm saying, and I want to be precise about what I am saying. There are tests that everyone, at every age, should have. There are screenings that have clear, well-established benefits across a broad population. There are investigations that are prompted by specific symptoms or clinical findings that absolutely must be pursued. There are conditions, in people of every age, that require monitoring, and that the monitoring genuinely serves. I am not questioning any of that. I am questioning the automatic, the reflexive, the routinely repeated without specific purpose. The test ordered because it's on the protocol, because it was done last year, because ordering it feels more thorough than not ordering it, without a clear answer to the question, what are we looking for, and what will we do with what we find? That question, what will we do with what we find, is one of the most important questions in medicine, and it is not asked often enough, because the answer to it changes depending on the patient. A finding that would lead to treatment in a 50-year-old may not lead to treatment in an 80-year-old, because the treatment itself carries risks that are not appropriate given the patient's overall condition, their other health issues, their ability to tolerate the procedure, and their own wishes about what they want from their medical care. If the finding won't change what we do, why are we looking for it? And if we are looking for it, we should be prepared to have an honest conversation with the patient about what we will and won't do if we find it. Before the test is done, not after. This is shared decision-making. It's a term that gets used frequently in medicine and practiced less consistently than it should be. It means that the patient has a genuine role in determining what tests they undergo and why. Not passive consent, signing a form because the doctor recommended it, but active participation in understanding what is being proposed, why it's being proposed, what finding it could produce, and what actions that finding might set in motion. After 65, this kind of participation is not just appropriate, it is essential, because the decisions compound on each other quickly, because the body's reserves are finite, because the time that medical investigation takes is time that means something different at 75 than it did at 50. I want to talk about a specific type of concern that I think warrants particular attention, and that is the relationship between testing and what we've come to call overdiagnosis. Overdiagnosis is a concept that is uncomfortable for medicine to reckon with, because it means that something we diagnosed was real, the finding was genuinely there, but that diagnosing it did not help the patient, and may have harmed them. This is different from misdiagnosis, where the finding was wrong. Overdiagnosis means the finding was accurate, but finding it was the wrong thing to do. This happens because of a fundamental feature of disease. Not all conditions that can be detected will, if left undetected, cause the person any symptoms or shorten their life. Some cancers, for example, grow so slowly that the person will die of something entirely unrelated before the cancer ever becomes clinically significant. Some structural changes in the body, in the heart, the spine, the vasculature, are real but benign in the sense that they would never have produced a problem if they had not been found. But once found, they require a response. And the response, the biopsy, the surgery, the radiation, the monitoring, the anxiety, causes harm that the original unfound condition never would have. The challenge is that we cannot always know, at the time of detection, which category a finding falls into. Medicine is not yet precise enough, in most areas, to distinguish with certainty the finding that would have caused harm from the finding that would not have. And so, understandably, findings are treated. But the treatment is not always better than the alternative of informed, watchful waiting, or of not having tested for the condition in the first place. After 65, this risk of overdiagnosis is heightened, not because older bodies are more prone to incidental findings, though they often are, but because the treatment of those findings in older bodies carries greater risk, and the time horizon within which the treatment might benefit the patient is shorter. The cost-benefit calculation shifts, and the patient, to participate meaningfully in that calculation, needs to understand that overdiagnosis exists, that finding something is not automatically finding something that needed to be found, that more information does not automatically mean better outcomes. There is something else I want to address that sits just beneath the surface of everything I've described, and that is the relationship between medical uncertainty and the body's own stress response. When a person receives an ambiguous test result, something that is not clearly normal and not clearly abnormal, something that requires follow-up to interpret, the period between that result and its resolution is not medically neutral. The anxiety it generates is physiologically real. Cortisol rises, sleep quality suffers, appetite may change. Social engagement often narrows as the person turns inward, rehearsing scenarios, anticipating conversations, preparing for possibilities that may never materialize. For an older person, whose cardiovascular and immune systems are already working with somewhat less reserve than they did in earlier decades, this sustained physiological stress response is not a trivial side effect of the testing process. It is a cost that accumulates across the weeks or months that an ambiguous finding might take to resolve. And in cases where the follow-up ultimately reveals nothing clinically significant, where the original finding was a variation, a shadow, a benign incidental detail, the patient has absorbed that cost for nothing, or rather, for a harm where they expected a benefit. I've seen patients age noticeably in the months between an uncertain result and its resolution. Not because of the underlying condition, which in many of those cases turned out to be minor or non-existent, because of the sustained psychological and physiological burden of not knowing, of fearing, of waiting. This is real medicine. This is a real outcome, and it deserves to be part of the calculation when we decide whether and how to test. The medical system measures its outcomes in tumors found and treated, in biomarkers normalized, in survival curves extended. It is considerably less systematic about measuring what testing costs the patient in anxiety, in lost sleep, in the quality of everyday experience during the months that investigations take. These things do not appear in outcome studies, but they appear in the faces of my patients, and they matter. So, what does all of this mean practically? What does it look like to be an informed patient in this territory? It means going into medical appointments prepared to ask questions, not just to receive recommendations. It means understanding that "we should check this" is a proposition that deserves examination, not automatic agreement. It means being willing to ask, why are we doing this test? What specifically are we looking for? What will you do if you find something? What happens if we wait, or if we don't do this test at all? These are not adversarial questions. They are not challenges to the physician's competence. They are the kind of questions that allow a physician to do their job better, to think about this specific patient in front of them rather than a generic protocol patient. Most physicians welcome these questions, even when they require a more extended conversation. It also means knowing your own priorities. After 65, and increasingly as the years pass, most people have developed a clearer sense of what they value most in their remaining time. Some want to pursue every possible test and every possible treatment because they find comfort and a sense of agency in the most thorough possible medical approach. That is a legitimate choice, and it deserves support. Others want to focus on quality of daily life, to minimize medical intrusion, to spend their time and energy on things other than navigating the medical system. That is equally legitimate, and it equally deserves support. What does not serve patients well is going along with tests and procedures without knowing what purpose they serve, because refusing or questioning feels presumptuous, because it seems like what responsible patients do is comply, because the system has a momentum to it that is easier to move with than to thoughtfully engage with. You are allowed to ask questions. You are allowed to take time to decide. You are allowed to seek a second opinion about whether a test is necessary. You are allowed to say that you want to understand the purpose of something before it happens, and that you won't consent to it until you do. These are not inconveniences. They are your rights as a patient, and exercising them is a form of taking your own health seriously. I want to share one more thought before I close, because I think it captures something important about the spirit of what I've been trying to convey. The goal of medical testing, at its best, is to serve the patient's well-being, not to achieve diagnostic completeness, not to reduce liability, not to follow protocols for their own sake, to genuinely serve the person sitting in the chair with their specific situation and their specific goals and their specific body at this specific moment in their life. When testing serves that goal, it is valuable, and I will always support it. When it diverges from that goal, when it creates burdens, anxieties, and cascades of intervention that the patient didn't understand or choose, it has failed at its fundamental purpose, even if each individual step along the way was technically defensible. The conversation I'm encouraging today is about closing that gap, about creating the conditions under which testing is genuinely purposeful, where the patient knows why something is being done, what it might find, and what will happen next. Where the decision to test is a real decision made by an informed person rather than a default that no one thought to question. After 65, that conversation has a particular urgency because the stakes on both sides of the equation are higher, because the potential benefits of catching something are real, but so is the potential cost of finding something that didn't need to be found. Because time is a more finite resource than it once was, and how that time is spent, including how much of it is spent inside the medical system, is a legitimate and important consideration. Ask the questions, expect real answers, take the time you need to decide, and find a physician who welcomes that kind of engagement rather than treating it as an obstacle. Because medicine at its best is a collaboration, and you are not a passenger in that collaboration. You are, or ought to be, a full participant. Before I finish, one thing I want to make absolutely clear. Nothing I've shared today is intended to discourage appropriate medical care, and nothing should be taken as specific advice about any test, procedure, or clinical decision in your own life. Every person's situation is individual. Every clinical decision involves factors that can only be evaluated by a physician who knows your full medical history and current